Hello, my name is David Reeves, and I'm a board-certified oncology pharmacist at Franciscan Health and professor of pharmacy practice at Butler University in Indianapolis. Monoclonal antibodies, in many ways, have revolutionized the treatment of cancer, and I will be discussing these therapies and their impact on the cardiovascular system. The first monoclonal antibody characterized was done in 1975, and rituximab was the first anti-cancer antibody approved in 1998. Since this time, there have been an explosion of anti-cancer monoclonal antibodies approved for therapy, with trastuzumab approved in 1998 and bevacizumab, another commonly utilized monoclonal antibody, approved in 2004. More recently, immune checkpoint inhibitors, which were first approved in 2011 with ipilimumab, have come to the scene. In all, by 2025, the market value of monoclonal antibodies is estimated to approach approximately $300 billion. Fueling much of this growth are the immune checkpoint inhibitors such as pembrolizumab and nivolumab. In fact, as of 2018, approximately 43% of patients with cancer were candidates for immune checkpoint inhibitors. As you can see in the bottom right-hand side of the slide here, their use and defined daily doses per capita has steadily increased since 2015 in the United States and abroad. Given the increased frequency of use of monoclonal antibodies, it is important to truly understand these medications and their impact on cardiovascular health. So monoclonal antibodies have evolved from the days of rituximab, which was a chimeric antibody that included a murine variable region, to more humanized and fully human monoclonal antibodies, which theoretically should have a decreased risk for infusion reactions. In addition, chemotherapy molecules can be attached to the antibody to provide direct delivery of the chemotherapy drug to cells that express an antigen of interest. Furthermore, bispecific T-cell engagers have been developed and are currently a really hot area of research and development. These take the variable region specific for a tumor antigen and couple it with a variable region specific for T-cells. Despite the commonalities among the monoclonal antibodies, their mechanisms do vary greatly. So you have some that bind the actual ligand, while others bind to the receptor, blocking signal transduction. Some block receptor dimerization and subsequent signaling, while others essentially bind to the tumor antigen and flag the cell for destruction by the immune system via antibody-dependent cell-mediated cytotoxicity or complement-dependent cytotoxicity. Those that have the chemotherapy or sometimes radiation therapy attached to the monoclonal antibody basically deliver the payload directly to the target tumor cells. As alluded to earlier, the bispecific T-cell engagers bind both a tumor antigen and the T-cells, essentially playing matchmaker and bringing the T-cell in close proximity to the tumor cell for destruction. Lastly, the immune checkpoint inhibitors, they really have no direct anti-tumor activity, but instead unleash the patient's T-cells on the tumor. They bind to either the tumor cells or the T-cells and block the interaction between the cells that would inhibit an immune response, thereby allowing the T-cells to identify the tumor cell as a cell that requires destruction. Targets of monoclonal antibodies are shown here. Many of the targets include a cluster of differentiation, such as CD19 and CD20. You can see here the CD19, CD3 bispecific T-cell engager, blinatumomab, falls into this category. You also have the immune checkpoint inhibitors that target either CTLA4, PD-1, or PD-L1, and the newest target of LAG-3 that was recently approved. In addition, there are multiple drugs targeting HER2, as well as others targeting the VEGF pathway and EGFR pathway, among various other targets. Despite their frequent use and depending on the agents, their relative tolerability, some do carry cardiovascular concerns, including the risk for acute effects such as infusion reactions and cytokine release, which can result in hypotension, as well as chronic effects such as hypertension, LV dysfunction, myocarditis, and atherosclerosis. One of the first monoclonal antibodies on the scene was bevacizumab, This targets the VEGF pathway, and along with ramucirumab, which targets the VEGF receptor, they are known to induce hypertension. Downregulation of the VEGF signaling by either binding to the ligand or binding to the receptor results in endothelial dysfunction and hypertension. This occurs in approximately 20 to 25% of those patients receiving these agents, and upwards of 10% demonstrate high-grade hypertension. Displayed on this slide is a proposed management for protocol for hypertension. This did appear in a publication concentrated on oral therapy and blockade of VEGF signaling. However, the effects of monoclonal antibodies should be similar to the oral therapies on blood pressure, and they're similar enough that they could be treated in a similar fashion. An essential component of management includes identification of patients experiencing hypertension, and for this reason, home monitoring is strongly recommended in order to reduce the tendency to excuse patients' elevated blood pressure as due to a white coat effect. Therapies recommended for patients with blood pressure elevations include inhibitors of the renin-angiotensin system, dihydropyrimidine calcium channel blockers, or carvedilol based on patients' comorbidities such as heart failure. Cardiomyopathy has been well defined as an adverse effect of HER2 targeted therapy. Blockade of HER2 signaling essentially results in impaired myocardial response to stress. It has been shown that about 10% of patients receiving adjuvant trastuzumab for breast cancer demonstrate a decline in the left ventricular ejection fraction, which increases up to 25% if they have received anthracyclines. And in the metastatic setting, the LVF reduction is noted in upwards of 25% or more, and the symptomatic heart failure may occur in 10% or more. Other anti-HER2 monoclonal antibodies appear to have a reduced impact on cardiac function. However, the data is more limited with these agents as they are newer to the scene, and many of these studies excluded patients with cardiac comorbidities. Anti-VEGF therapy can also cause cardiomyopathy. However, this is more likely due to their vascular effects, including hypertension, thrombosis, impaired vascular function, and others. This is another reason why monitoring and management of hypertension while receiving anti-VEGF therapy is so important, so that we can prevent this potential cardiomyopathy down the road. The European Society for Medical Oncology published consensus recommendations for the management of cardiac disease in cancer patients and include this proposed framework for monitoring and management of LV dysfunction during treatment with drugs associated with cardiomyopathy. This includes a baseline cardiac workup with a baseline measurement of LVEF. Patients with a normal left ejection fraction may start treatment, while those with lower left ejection fraction should consider non-cardiotoxic treatments. While receiving potentially cardiotoxic therapy, patients should have their LVEF monitored approximately every 3 months or as clinically indicated. And during this time, if they experience symptomatic heart failure or they have an absolute LVEF decrease more than 20%, therapy should be withheld. Those with an absolute LVEF decrease greater than 10%, or if the absolute value drops below 50%, they should have their therapy withheld. And upon further workup, if the LVF returns to baseline, they may be reinitiated on therapy, however, potentially at a lower dose. Otherwise, they should be treated with cardioprotective therapy and started on a non-cardiotoxic regimen if possible. Multiple studies have been completed investigating cardioprotection during and after anthracycline therapy. However, data with HER2 therapies is generally lacking. 2 studies did investigate cardioprotection with a beta blocker or an ACE inhibitor or placebo in patients receiving HER2 therapy. Both studies looked at breast cancer patients and included a year's worth of therapy. Anthracyclines were used in both studies, with 23% receiving anthracyclines in the first study and 40% in the second. In the first study, a decline in LVEF was less common in those receiving bisoprolol and perindopril, and in the second study, a larger effect occurred in those also receiving anthracyclines, which is to be expected. However, in the full population, cardiotoxicity-free survival was longer in those receiving either carvedilol or lisinopril compared to placebo. Immunotherapy, including the immune checkpoint inhibitors and bispecific T-cell engagers, can also cause cardiotoxicities. The pro-inflammatory effects of the immune checkpoint inhibitors has been shown to induce myocarditis, as well as vasculitis, pericarditis, and arrhythmias. The bispecific T-cell engagers can induce the release of pro-inflammatory cytokines, resulting in cardiomyopathy and vascular leak. For immune checkpoint inhibitors, cardiotoxic effects tend to be relatively rare, generally 1% or less, but these are relatively new drugs to the scene, and the cardiotoxic effects may not be fully characterized. The majority of patients, if they are going to experience myocarditis, typically develop it within the first 2 months. If a patient is suspected of having myocarditis, immune checkpoint inhibitor therapy should be immediately withheld pending further workup, and due to the inflammatory mechanism, treatment of myocarditis revolves around really reducing that inflammatory effects of the immune checkpoint inhibitors with medications such as methylprednisolone, mycophenolate, IVIG, infliximab, as well as something like the CTLA-4 agonists such as abatacept or belatacept may be used in more refractory cases. Atherosclerosis can also occur in patients receiving immune checkpoint inhibitors and are associated with a threefold higher risk of atherosclerotic cardiovascular events. Likewise, due to the vascular effects of VEGF pathway inhibitors, atherosclerosis may be accelerated among those receiving bevacizumab or ramucirumab. Risk assessment, healthy lifestyles, and risk factor management are particularly important in patients receiving these therapies due to the increased risk for atherosclerosis. Of note, those receiving immune checkpoint inhibitors, the increase in thoracic plaque volume that was noted was actually lower in those receiving statins and corticosteroids. And due to the inflammatory nature of the immune checkpoint inhibitor-induced atherosclerosis, potential protective therapies proposed include things like statins as well as corticosteroids. However, corticosteroids, if you use those, you have to balance that with the potential for decreased response to the immune checkpoint inhibitors. And lastly, possibly something like colchicine to decrease some of those inflammatory effects. So in conclusion, monoclonal antibodies are not going anywhere anytime soon. In fact, their utilization is likely to increase. The use of immune checkpoint inhibitors continues to increase at a rapid pace, and new bispecific T-cell engagers are currently being investigated in multiple malignancies, including prostate cancer, lung cancer, and GI malignancies. In addition, new combinations of therapy are continuing to be investigated, including combinations of immune checkpoint inhibitors and things like oral anti-VEGF therapies with the potential for additive or synergistic cardiovascular effects. At this point, the most important thing that we can do for our patients is to really conduct a thorough baseline risk assessment and continually monitor for cardiovascular impacts so that they can be identified and managed earlier. I'd like to thank you for taking the time to listen to this introduction to anti-cancer monoclonal antibodies and their potential impacts on cardiovascular health.